Good afternoon and welcome to Facebook Live with Holy Cross Health. My name is Brenton Andrasic, Manager of Physician Alignment and Business Development for Holy Cross Health. Before we begin, I'd like to call your attention to a few ground rules that you'll see in the comments section. We encourage you to participate, but please keep any questions and comments general. We won't be discussing any specific health situations in this public forum. If we can't get to every question today, we'll provide additional feedback through our website, or we'll connect with you one-on-one via our phone or website channels. For those of you joining us today on Facebook, we thank you for being here and for taking an active role in your health, and we at Holy Cross are happy to be your partner in your health journey. Today we're here with Dr. Richard Silva, vascular surgeon at Holy Cross Germantown Hospital. Dr. Silva is an experienced surgeon specialized in the diagnosis and treatment of vascular diseases. Using the latest minimally invasive endovascular methods and surgical procedures, Dr. Silva restores blood flow to blocked arteries and veins. So, Dr. Silva, welcome. Can you tell us what is a vascular surgeon and what are some of the things that you typically treat?
Well, a vascular surgeon is a medical specialist who takes care of the circulatory system. And that essentially means we deal with all arteries and veins outside of the heart and the brain. So we deal with anything that falls in those realms, from blocked arteries and veins to the arms and legs, blocked arteries to kidneys and the intestine, as well as aneurysms in the abdomen and belly, or abdomen and legs. We do a lot of limb salvage. That's one of our most rewarding things. We get to open arteries and save legs. And then we deal with the vein system, where we deal with blood clots, blocked veins, and all sorts of bleeding in traumatic issues, as well as in the operating room when other surgeons need us.
Right. And so that's obviously quite an extensive list of things that a vascular surgeon has to know how to deal with. One of the most common things that our viewers might be interested in that impacts your practice is varicose veins. So I wanted to take a few minutes to dive a little bit into varicose veins, and if we could just start off with, what's the physiology of varicose veins? How does that happen that someone winds up with that disorder, and what's really causing it?
Well, that's a great question, and there are a lot of reasons for it, some of which are genetic. I always tell my patients, you get it from your parents and you get it from your children. And so genetics, of course, don't go up, but pregnancy will lead to a lot of varicose veins. So it's genetics, it's lifelong standing, lifelong sitting. Certainly people have laxity in tendons who get hernias, and flat feet tend to have the higher risk because their collagen seems to stretch a little easier than other people's.
Right. And so I think that covers some of the risk factors, but so on a physiologic basis, what's really happening? What's actually causing the veins
So what we're
to
really
bulge?
getting is increased pressure in the veins for whatever reason, whether it's you're overweight or you're pregnant or you're standing all the time. But the extra pressure in the venous system leads to stretch of those veins. That stretch leads to the valves in the veins not functioning, and then the cascade continues. The lower down vein feels that pressure, and the next valve gets hit with that pressure and stretches and doesn't work, and then the vein stretches to a point where you get to see it, or it causes symptoms.
Right, so it's a bit of a cascade of impacts. So you mentioned symptoms, and we touched on it a little bit, but talk a little bit more about what someone might be experiencing if they are having varicose veins.
Most commonly when they have varicose veins, they come in complaining of the visibility of the varicose veins, but it also is associated with discomfort in the legs. So people have, certainly bleeding veins can be one of them, but more commonly it's heavy, tired, achy legs. And sometimes they don't even attribute it to the veins. It's just, I've been living my life and my legs just feel tired, and they get worse the more the day goes on. And so those are the things that bring people to see us.
Right, right. So you mentioned people coming to see you for this. When should someone really make that decision to say, okay, this is a problem that's serious enough that I should go and seek help from a physician?
Now, there are a bunch of scenarios where that happens. Like I was saying, number one probably is the visibility of the veins. They don't like the way they look. And then when I speak with them, they realize they do have some symptoms. Other driver is the actual symptoms. We see just leg pain every day in our office. My legs hurt, they're achy, they're sore, and then we investigate and find venous insufficiency. The other thing is swelling. Certainly a swollen leg always drives people to see the doctor and commonly ends up in our door. And then wounds. Vein disease not only causes those symptoms, but it can cause breakdown of the skin, primarily around the ankle. And that's because of that pressure hurts the skin there. And then it doesn't take much for that a wound to develop, and it's very slow to heal. So we see those people as well.
So let's say someone has noticed some of these symptoms, maybe they have some of the risk factors that we talked about. They come to see you in the office. What's the diagnosis look like? Obviously, this is a very visual disorder, but what's the process that a patient could expect to go through in the office?
Well, when you come to see us, we do a thorough history, find out how long it's been going on, what symptoms they're having, a good physical exam, take a look at their legs, feel their pulses, make sure we think it's venous disease and not something else. And then if we're convinced that it is related to veins, or if we're unsure, we'll do an ultrasound in the office, which of course is a painless, simple, straightforward test, which is very good at detecting insufficient veins or blood clots in the legs.
So someone comes in, they have the symptoms, they come in, go through history and physical, get the ultrasound. Okay, it's varicose veins. What sort of treatment options exist, and where could someone expect to get those treatments?
Well, I'll kind of run through what I do in my office.
Sure.
I see somebody and I've made sure it's not a blood clot. If it's a blood clot, of course, you use blood thinners. But if it's varicose veins, venous insufficiency, we start with conservative therapy, which means I tell everybody exercise, elevation, weight loss, and support stockings. And then they'll come back and see me after usually a 2 to 3 month trial period of that. If they're still having symptoms despite the stockings, then we start talking about the interventions that can be done. And we'll do, based on the ultrasound, ablation of the bad veins. The interesting thing about
ablation, meaning?
We'll get there. It means get rid of the bad veins. We don't have the ability at this point in time to replace the valves or do anything that actually fixes the veins. But when we're dealing with the varicose veins on the surface of the leg, they aren't helping in any way, so we just go get rid of them. And in the old days, we would tear the vein out of there, and it was the worst operation ever. Now we have much more elegant, in the office, very simple, straightforward, low pain, low risk procedures that get rid of the bad veins and make the leg feel and look better. Now, when things are a little more extensive, that's where we start talking about procedures that are either done in an angio suite or in the hospital. Like Holy Cross Germantown, we go and we can open up blocked veins that are here that are leading to the problem. And those are slightly bigger procedures, still done as an outpatient. You come in, you get it done, you go home.
And what portion of patients would you say fit that bill of having to go to the hospital for a larger procedure versus being able to be treated in the office?
I think that it's a tricky question, because if you take people who come to my office, the majority of the time we're going to take care of them in the office because they aren't the more acute phase people. But with this disease process, particularly DVT, I mean blood clots in the veins rather than venous insufficiency, those people end up in the hospital and they're prime candidates to be treated in the hospital. And the majority of those people probably would get treated in the hospital if their symptoms were that dramatically bad, they needed a procedure.
And so tell us a little bit about recovery. Let's maybe focus on the less severe aspect in which someone is able to either they've had successful treatment without procedures, or they've had a relatively small in-office procedure. What does that recovery process look like? How long could someone expect to go until they're at normal, or will you sort of never be at 100% following that?
Well, we want everyone to be 100%. Now, when you start talking about the treatments we've given people, we start with a conservative treatment of support stockings and exercise and elevation and weight loss. And those people, they're managing their symptoms. They stop wearing their stockings, their symptoms are going to return. So that's not a cure per se, but it is a way that you can live your life, be very comfortable, and not have to have procedures. When that doesn't work, and we do these smaller in-office procedures, the procedure itself takes 15, 20 minutes. It's safe, low risk, and you go home. I tell people nothing strenuous for about 5 days, but after that, they're free to do whatever they want to do. Now, there may be a couple extra steps depending on how bad their vein disease was. Sometimes they'll get a second or even a third procedure. More commonly, we knock things out with one procedure. And then after that, we set them free, we keep an eye on them, they know where we are, and their symptoms do return, and anybody who has the propensity to have varicose veins will tend to get more over time. So the more you wear your stockings, the less you'll have to come back and see me again.
Right, right. Although as much as I'm sure people would love to come back and see you.
Oh yeah, they all do.
So I think that we did a pretty good job of covering varicose veins. We could certainly talk for a lot longer about that topic, but I want to make sure we have time to cover a few other things. You know, you mentioned DVT or deep vein thrombosis, related process, but not entirely the same. And so I want to sort of talk about clotting issues in general, about DVTs and also PEs or pulmonary embolism. Could you tell us a little bit about what DVTs and PEs are and what's really happening in the body when those things occur?
So we'll sort of separate
Yep.
the two. A deep vein thrombosis, or a DVT, is a blood clot that forms in the deep veins. And the most common spot is going to be the legs. The reason people get those can be no reason at all. There are three sort of general categories where we think have higher risk, and one is when people are lying around sick, had surgery, so that would we call that stasis, or just slow moving blood. The veins are just, the blood flows slower, and you make it even slower, it has a higher risk of clotting. And then an injury to the vein, so people have had surgery, any trauma to the leg, you twist an ankle, you get a knee surgery, those people have a higher risk of getting a clot because of the trauma to the leg and the veins. And then there are people who have increased clotting of the blood. They're hypercoagulable, we say, so their blood clots easier. And those people have a higher risk of clots. And those are the general three categories that we worry about. But the risk factors for blood clots follow a lot of the risk factors for the venous insufficiency: obesity, genetics, what else? Pregnancy, and
Cancer.
What's that?
Cancer.
Cancer, of course, I was getting there. And certainly cancer can be a risk factor for that as well.
And so I think it probably makes sense to maybe look at DVTs and PEs a little separately. So in a deep vein thrombosis, we talked about some of the risk factors. What would someone be experiencing symptom-wise if they were suffering from this?
So a DVT tends to, you can have no symptoms of it if it's a small DVT. More commonly, it's leg swelling and leg pain, and it's almost always unilateral, one side or the other. You could have both sides have blood clots, but it's more common it's going to be one side or the other, and you come in with a swollen leg. The first thing we do is our history physical, and then we lead to the ultrasound, which is an excellent way to diagnose a DVT. And after that, we know the diagnosis, and the treatment becomes straightforward.
And same question for the varicose veins as before. When should someone really be concerned that they might have a clot that is requiring a physician's attention?
That's a very good question. I would have to say that anybody who has leg swelling of any kind that's acute onset should drive somebody to see their physician or see a vascular surgeon. Anything that changes like that. So there are people who have leg swelling day in and day out. Very unlikely that that's going to be a DVT. So it's going to be an acute change, especially if you have one of the things we mentioned, an injury to the leg, or you came back from China, or a long flight or long car ride. Those things are high risk for getting a clot. And one-sided leg pain, one-sided leg swelling, or even both acutely, you're going to want to have that investigated.
Right. Yeah. All important things for people to be on the lookout for, especially in the context of some of those risk factors that we mentioned.
Yeah.
Let's say that someone does suspect that they have a DVT. They come in, get it checked out, and it's confirmed. What does the treatment look like?
Thankfully, nowadays it's much nicer than it used to be. And not too long ago, we would be on Coumadin, which required you to change your diet and have your blood drawn frequently. Now we have much nicer anticoagulants, so we put you on blood thinners. And once you're on the blood thinners, you're really quite protected from that clot. It tends to not grow or not move, and then you can go about living your life taking your medication. We keep an eye on the clot with an ultrasound periodically, and after 6 months-ish, 3 to 6 months, depending on how bad the clot was, we may stop the blood thinners and set you free.
So while we're on the topic of clotting issues, I wanted to circle back to pulmonary embolisms. What are some of the symptoms that someone might experience if they're having a pulmonary embolism?
So a pulmonary embolism is essentially just a blood clot that moves from, we'll call from the legs or anywhere in the body, but moves up, and the next stop is the lungs. And that's where you get your symptoms from. Now, a blood clot in your leg won't kill you, but a blood clot that moves to your lungs potentially can. And the symptoms most people have are going to be chest pain, shortness of breath, fast heart rate, and not uncommonly syncope, passing out. That drives a lot of patients to the emergency room. I passed out, didn't know why, and they investigate and they find they had a pulmonary embolism.
Right, and what sort of treatments do we have available to us to treat pulmonary embolism?
Well, thankfully, the mainstay of the treatments is the same. You start people on blood thinners, and they're protected again from that clot growing and protected from any other clots getting up to the lungs. But when people have these, we call them massive or even submassive PEs, that means your blood pressure is low, you can't catch your breath, you need oxygen. Those people, there are a lot of nice procedures now where we go in through the veins and either suck out that blood clot, or we instill blood clot dissolving medicine into that blood clot, and it helps clear out that clot so that the heart can function normally and the lungs can continue doing their job. There's also open surgeries, which we don't do. I personally don't do, but most people don't require that because the other procedure is so much nicer than having your chest opened up.
Of course,
but sometimes it's required.
And tell us a little bit more about some of those procedures and the recovery that would be expected if you did need to have one of those done in the hospital.
So again, you come in because you have the symptoms, you've diagnosed with the pulmonary embolism. If you're one of these massive PEs and it's life-threatening, we get you into the angio suite where we'll suck out that blood clot or infuse the blood clot dissolving medicine. And thankfully, that's a puncture wound. We commonly go through the neck. And the recovery is just from a puncture wound, so it's a pretty small recovery. Now, you still have to get over the whole event that you just had, so you end up spending a day or two, maybe even longer, in the hospital while we make sure your heart's strong and your lungs are functioning well and you get adapted to the blood thinners. And then we can think about getting you out of the hospital. Right. So it's good 2 to 3 days at least after.
So we got a couple questions in, so I wanted to address those about DVTs and also circle back to varicose veins before we move on. Someone asked if they have a swollen leg and it's been evaluated and it's not a DVT and they don't have any signs of a pulmonary embolism, how many days, I was trying to parse this one out here, how many days would it be recommended for them to have a DVT evaluation?
Well, once you get an ultrasound that says you don't have a DVT in that leg, it's very unlikely that you actually have one. Now, some people will end up getting a second ultrasound in a month or two if they go see another physician and they haven't heard the report from the first one. But once you're sort of cleared of a DVT by the ultrasound, there's no great need to go and get another ultrasound to evaluate that. And ultrasound is the best test. So there's no other great tests that would show something that an ultrasound doesn't.
Right.
Now, depending on the ultrasound, you may say, if they didn't get to see everything they want to see, you may say, I'm going to get a repeat just because they didn't get to look at the smaller veins in the calf.
Got it. And so hopefully that's helpful for our viewer. A related question, someone wanted to know, when should I ask for a thrombectomy or TPA after a DVT? Perhaps a question for our stroke event that we had earlier, so it would also refer you to our previous Facebook Lives, but Dr. Silva, if you'd like to address that.
So the majority of DVTs, you don't need a thrombectomy or, what was the other thing?
TPA.
TPA. Most of the time.
You could describe what TPA is.
TPA is, I always just phrase it as blood clot dissolving medication. It's strong stuff that you infuse into a blood clot and it helps the body melt it away. So it works very well in the acute. I have a clot within the last 2 weeks. As it gets older, it gets a little less effective. But for a blood clot in the leg, if it's not, the leg isn't persistently markedly swollen with a lot of pain and discomfort, most people get put on blood thinners. The leg does tend to improve very quickly and they don't need any interventions. And given time, it clears up, the leg goes back to normal. The veins are never normal again, but the leg tends to look normal, feel pretty well, and you can continue on without the blood thinners after a full course of the treatment. Now, if your leg is persistently large and swollen, that's when you start thinking, okay, I need an intervention. Now, that sometimes is challenging because the decision to do that intervention should be done sooner than later, because the benefits and the success are much better when you do it within the first 2 weeks.
So we also had someone ask about varicose veins, so I wanted to circle back around to that before we move on. They wanted to know, well, first of all, they had radiofrequency ablation, so perhaps we could discuss that a bit. But that had failed to remove the visible veins, so they wanted to know if phlebectomies or other methods are helpful in reducing the visibility of the veins.
The answer to that is yes. So a radiofrequency ablation of the vein is what we use to treat the sort of truncal veins, the main veins that lead to the varicose veins that you see. So we would go, and that's sort of the 15-20 minute procedure I described. We go in, we slip a tube into that vein, and we burn it closed. Now that will kill off that vein, and it usually decompresses the bigger branches that people see that they don't like. And those branches also cause symptoms. So even if you get rid of the main culprit vein, you've done the leg a service, but you might not have solved the problem. And so what we end up doing is, if they still have symptoms, we go chase these tributary veins, we call them, these varicose veins that are still prominent, still leading to symptoms, or cosmetically also aren't pretty, although I love the look of them. But we can do that with phlebectomy, which means make cuts and pull out the veins. Or what we more commonly do nowadays is chemical ablation, where we inject a chemical into those veins, massage it around, and it kills off those veins, and they'll go away over the next 2 to 3 months, giving us a nice cosmetic result as well as alleviating the symptoms.
So I think those are the questions we have for now, so please keep them coming if you have any additional questions. Certainly good information for everyone there. We have a little bit of time left, so I wanted to spend some time talking about aneurysms, another vascular disorder that in a lot of ways is more emergent than some of the things that we've discussed, although clots can certainly be very emergent. Could you tell us a little bit about an aneurysm, what it is, and what's physically going on when that happens?
So we deal with aneurysms in the peripheral circulation, the aorta and the legs and the arms, but essentially an aneurysm is a weakened artery. So opposite of veins, veins bring blood back up. These arteries bring blood out to the legs and the hands. And when those arteries get weak and the walls get weak, because usually risk factors, which include genetics, smoking, cholesterol, and hypertension, high blood pressure, that weakens the wall, and it slowly gets bigger over time. And as it progresses, the bigger it gets, the more dangerous it is. We deal primarily, the most common aneurysm we deal with is one in the abdomen, and that's a difficult one to identify because unless you get a CAT scan or you're fairly thin, you don't notice it until it gets to be a sizable aneurysm. And those aneurysms in the belly, what they have a propensity to do is once they get to a certain size, they want to pop and rupture, and then it's, like you said, very emergent. Most people aren't going to survive that. If you get to the hospital and get some emergency surgery, which we do at Holy Cross Germantown, it can be a successful fix, but you got to get there quick.
Right, and knowing that time is of the essence when something like that does happen, what are some of the signs, symptoms that people should be looking out for?
So aneurysms don't tend to have any symptoms until they rupture, which means you get this terrible abdominal pain, sometimes it's terrible back pain, and you don't want to go sleep that off. You want to sort of say, this isn't going away right away, I'm going to the emergency room.
Right. It's an important message to get out there.
Yes.
If someone does have an aneurysm, what does the diagnosis and treatment look like? You mentioned some of the more emergent treatments, but what could someone expect to happen?
So most commonly they're identified because of another test that gets done for back pain or gallbladder pain, and you get an ultrasound, you get a CAT scan or an MRI, and it shows an aneurysm. And that's where we see these people, and we follow those along, and we keep an eye on them with ultrasound. And if it gets to a certain size, and we usually between 5 and 5.5 centimeters, once it gets to 5.5 centimeters, we certainly think if you're a healthy enough person to tolerate the surgery, it makes sense to fix that. Thankfully, in the old days, we did operations where we made these big incisions through the whole abdomen and a week in the hospital, and a very painful procedure, but very successful. But nowadays, we do that same operation in half the time through 2 tiny little incisions, 1 in each groin, and you come in, you get it done, you stay overnight, and you go home the next day on the golf course in a week. So it really is the technology has changed the aneurysm game tremendously. So it's a great operation. It does a nice job fixing the problem, and it keeps people alive, and it gets them back to their lives very quickly.
Yet another great example of the advances and innovations in minimally invasive surgery being advantageous for patients and speeding along recovery.
Absolutely.
So we've talked quite a bit about varicose veins. We talked about deep vein thrombosis, pulmonary embolism. We covered aneurysms a little bit, but that's obviously not all that you, Dr. Silva, treat, or all that Holy Cross treats in the realm of vascular surgery. What are some of the other conditions that you treat and some of the other symptoms that you might be able to help patients with?
So stroke prevention is one of the things we really specialize in. So the risk factors that cause aneurysms are the same that cause blocked arteries everywhere, heart or anywhere else in the body. It's blood pressure, it's cholesterol, it's diabetes, it's cigarettes, and genetics, of course. And so we deal with the carotid arteries. When they get narrowed down, people are predisposed or high risk for stroke. The narrower it is, the higher the risk of a problem. And so we keep an eye on those with ultrasound as well. And when they get narrow enough or they cause a symptom, then we go and we clean that artery out with some nice, again, elegant small procedures to open that up. The other thing I mentioned earlier was limb salvage. We want to keep people's legs where they are, so we use a lot of angioplasties and stents and lasers and other technologies to keep the arteries open and keep the legs where they belong.
Well, I don't think that we have any additional questions at this time. So I think that, look, we are just about out of time. So thank you everyone for tuning in today. If we didn't get to your question, we're planning to provide additional information on our Holy Cross website, although I think we did get to everyone's question, so that's excellent. Thank you, of course, to Dr. Silva for joining us today and offering so much tremendously important and valuable information for us and for our patients, so thank you. To connect directly with Dr. Silva or any vascular surgeon, you can visit holycrosshealth.org/findadoctor, or you can call us at 301-754-8800. So thank you for joining us today on Facebook Live with Holy Cross Health, and we hope to see you again soon.